Microwave endometrial ablation. It utilizes magnetic energy and works at frequency of 9.2 GHz. It is an OPD procedure done under local anesthesia. It uses an 8 mm applicator with no need of preoperative endometrial thinning. Temperature of 80 degrees Celsius is maintained for 3 minutes. About 50% become oligomenoric, 40% amenorrheic. Up to 6 mm endometrium gets ablated. No earthing is required unlike TCRE. Total operating time is 12 minutes. Hysteroscopy is also not required. Contraindication and complications are similar to other procedures. Vesta system. This system uses a single-use multi-electrode intrauterine balloon to ablate the endometrium. The silicon inflatable electrode carrier has a triangular shape which unfolds when its insertion sheath is withdrawn. The controller unit is connected to a standard electrosurgical generator. It regulates energy to each balloon electrode plate. The temperature set is 75 degrees centigrade. Procedure takes about 5 minutes under local anesthesia. 90 to 94% are cured of menorrhagia. Uterine tamponade. In acute episode of bleeding, by inserting a Foley catheter, distending with 30 ml fluid and leaving the catheter for 24 hours. NovaSure is the latest and most safe procedure, taking just 90 seconds. It uses bipolar radio frequency and vaporizes the endometrium up to the myometrium. Endometrial laser intrauterine thermotherapy ELITE is a new laser therapy that destroys the entire endometrium as well as 1 to 3.5 mm of myometrium. It is done as OPD procedure, takes 7 minutes. The machine is known by the name GyneLase. Both touch and non-touch technique can be employed. Bilateral uterine artery embolization. Primary used in uterine fibroid, this technique is extended into intractable AUB in young women to preserve her reproductive function. It is also useful in AUB complicated by varicose uterine vessels. Hysterectomy. It is required if the medical or minimally invasive surgery fails or menorrhagia recurs. In older women more than 40 years not desirous of childbearing can opt for hysterectomy. If performed by abdominal route, initially performed by abdominal route, it was replaced by laparoscopic hysterectomy or laparoscopic assisted hysterectomy for its quick recovery, less pain, less abdominal adhesion, and avoidance of abdominal scar. Many gynecologists also have shifted to vaginal hysterectomy for undescended uterus, which may be enlarged. But it is contraindicated if the uterus is grossly enlarged, previous surgery with possible adhesions, fixity, and limitation of uterine mobility, the presence of endometriosis or adnexal mass. Sequelae or delayed complications of hysterectomy. Although hysterectomy is a one-time procedure, safe and cures AUB, delayed complications are ovarian atrophy due to devascularization. The woman develops menopausal symptoms and its complications. Adhesions of the ovaries to the vaginal vault causing an residual syndrome, dyspareunia, chronic pelvic pain. Vault prolapse. Sexual dysfunction, dyspareunia due to short vagina. Chronic abdominal pain due to post-op pelvic adhesions. Urinary and bowel symptoms due to denervation and psychological disturbances. New systems include Versa Point, bipolar electrosurgical system, works in normal saline, is cheap, has excellent hemostasis, and causes instantaneous tissue vaporization. Advantages of Mirena IUCD over ablative techniques are: it is low cost, it's an OPD procedure, preservation of fertility after its removal. Pregnancy occurs within 1 year. The only disadvantage is occasional systemic side effects of progesterone. Adenomatous endometrial polyp. This form of polyp is a localized area of endometrial hypoplasia when area of thickened endometrium projects into the cavity of the endometrium to look like a polyp. The polyp may be single, multiple, small or large enough to protrude through the cervical canal. Mostly they are sessile and small. This type of polyp occurs in endometrial hypoplasia, metropathia hemorrhagica, tamoxifen, a woman on tamoxifen, and some cases of fibroid pathology. A polyp is covered by cubical epithelium and contains endometrial glands that do not respond to the hormones. These polyps cause menorrhagia, metrorrhagia, postmenopausal bleeding. The uterus is normal in size, slightly enlarged uniformly. Ultrasound, sonosalpingography, and hysterosalpingography detect this polyp but may miss them if they are very small. Hysteroscopic visualization and resection is the best treatment. Hysterectomy can be avoided. Histopathology is mandatory to rule out a malignant change. Adenomyomatous polyp resembles adenomatous polyp but it contains muscle tissue in the stroma. The symptoms and management are similar in both conditions. AUB in adolescents. The commonest cause lies in HPO dysfunction, immature development of these organs, hypothalamus, pituitary, ovaries, result in anovulation in 1 to 5 years following menarche, unopposed estrogen causing endometrial hyperplasia. As the girl matures, the normal menstrual cycles are established. Blood dyscrasia, coagulation disorders, thrombocytopenic purpura, von Willebrand disease, leukemia account for 20% of the cases. Hypothyroidism occurs in 4% of the cases. PCOD 10 to 12% of the cases. Genital tuberculosis 4% of the cases. Liver disorders, feminizing ovarian tumors, granulosa cell and theca cell tumors, or adrenal hyperplasia. Clinical features are menorrhagia may be noticed from the start of the menarche, but often the initial cycles may be normal. It takes the form of heavy regular cycles or normal bleeding lasting for several days, but dysmenorrhea is invariably absent in an ovulatory cycles. Anemia may supervene. The pelvic findings by ultrasound scanning are normal except in ovarian tumor. It is important to rule out other causes of menorrhagia before instituting hormonal therapy. Investigations. Blood profile. Hemoglobin profile, percentage, bleeding, clotting time, coagulation factors, blood film, X-ray chest for tuberculosis, thyroid function test, pelvic ultrasound to rule out PCOD or an early fibroid. If medical treatment fails, DNC should be done to rule out endometrial tuberculosis by PCR test. Management. The aim is to control menorrhagia, prevent and treat anemia, prevent the recurrence, treat the cause. Anovulatory cycles. In acute episode of bleeding, Premarin 25 mg 6 to 8 hourly will control the bleeding in 24 to 48 hours. Thereafter, estrogen for 21 days with progestogen is added for 10 days for 3 to 6 cycles will regularize the cycles. In chronic menorrhagia, oral combined pills or cyclical progestogen is the first line of treatment. About 70 to 80% respond well. NSAIDs, mefenamic acid 250 to 500 mg TID during the periods. Naproxen, ibuprofen can also be tried. Androgens, danazol are not recommended, though effective because of the androgenic effects in young girls. GnRH therapy takes 4 weeks to act, so not useful in acute episode. The drug is expensive and prolonged treatment for more than 4 to 6 months can cause osteoporosis. If progestogens cause side effect, Mirena IUCD for few months can control menorrhagia. Arterial embolization is required in a varicosity of uterine vessels. When the above treatments fail, uterine tamponade using Foley catheter for 24 hours can control bleeding in acute episode. Anti-TB treatment in endometrial tuberculosis. Blood transfusion may be required to correct the anemia. Lately, the trend is to give IV tranexamic acid 1 gram with 25 mg estrogen and then continue with estrogen and progesterone as mentioned. Desmopressin analog of arginine vasopressin is given intravenously or by a nasal spray 1.5 mg per ml up to a total of 150 to 300 microgram diluted in 30 ml saline in Val Willebrand syndrome. Tranexamic acid inhibits tissue plasminogen activator, which is a fibrinolytic enzyme whose levels increase in AUB.